Hi there. We are privileged to have one medical doctor who is a Ghanaian who has actually developed a medical technique that can be used to perform medical surgeries remotely. I mean, you could be living in Savelugu and have doctors in other parts of the world, the United States, the UK, conduct surgeries on you without you even traveling to the United States. Yes, you heard me right. The doctor who has been able to master that technique is a Ghanaian. He is John de-Graft Johnson. We are privileged to have him here on the show so we can dig deeper into this conversation. Right, tell us about this technology that you actually are working with.
So thank you, first of all, Carlos, for having me here. I'm sincerely grateful and I appreciate the opportunity to speak with you. So what we are talking about is the idea called tele-manipulation surgery. What does that mean? It means that one sits at a consult, manipulating the technology, and it's a remote arm that's operating on the patient.
Right.
Now, there are several different companies that develop this thing. We have the US-based one, which is the primarily one that I use, called the Da Vinci robot. And then there's also the Microport, that is the Chinese company, and even India has just recently released their own called the SSI. So there are different, names out there, and I'm not, glued to one or the other, but
Right.
these are just the options that are available.
Okay.
But the idea is the same. What it is that you just kind of control it, and it transmits your movement to the distal end of the tentacles that allows you to operate on the patient.
Beautiful. So tell us how different this is compared to the traditional way of conducting surgical procedures.
So, for example, in order for me to access your heart, for example, during an open heart surgery, it requires me to, number one, take a knife, cut the skin to the breastbone. Then I need a saw to literally saw open your breastbone.
Wow.
Then I need to put a retractor to spread open those breastbone to gain access into your chest to start conducting the preparation. So one can imagine the trauma that it takes to go through all the layers of the skin, the muscles, then the bone, and then spreading it open to gain access just to do the surgery. What if we don't have to do that? Suddenly we are avoiding the collateral damage that we deem necessary to gain access. So we are sneaking in between the ribs, gaining access through tiny little incisions and doing the exact same surgery we will be doing, except we are avoiding the access to your chest by, quote unquote, cracking your chest open. So
say that again. It means that with this technology, you aren't going to open up the patients?
No.
You use tools.
That is correct. So instead of making that incision, the midline incision that we'll do, we're making tiny little ports on the side.
Okay.
And then going through, and the size of the hole is about the size of a pencil.
Wow.
That we're going through, and we make several of them, and then to gain access into your chest. And once we do that, now with my naked eye, I can see very well, and we use magnifying glasses.
Right.
But even with the magnifying glasses, I can only see 2 times the natural vision or 3 times the natural vision.
Okay.
With the robot, it allows me to see 10 times.
So that's for precision and accuracy?
That's precisely accurate. So it is tremendously magnified, and I can see well and in finer details. And not only that, the arm movement, the robot has various degrees of freedom in the movement, even more so than the regular human hands. So I can get into angles and crevices in the body that will be difficult for my big hands to do. And that's, by the way, the only reason we make the incision so big, so I can get to where I want to go to.
Okay.
But with the tiny hands, you don't have to.
But people believe that anything made by man has a margin of error. So with this technology, what is its margin of error?
So I always tell everybody I offer surgery to that I play a game of 98 to 99% to the game of 1 to 2%. What do I mean by that? everything that I'm doing, I can promise you that I'm going to be 98 to 99% accurate, and everything will go well,
Right.
and you go back home as promised, as advertised. However, 1 or 2%, something bad could happen. And, whoa, what does that mean? Somebody may say that, well, 99% is pretty good. But if you are the 1%, it's still 100% bad.
Yeah.
And so this is where all of us become humble, and all of us proceed with caution, and all of us have a dose of humility. And we have to be extremely careful to pick the right patient that we think this will be successful. Okay. But then I quickly remind them that, well, on the day of your surgery, it turns out that I have to drive from my house to the hospital to do your surgery. That rule applies to me too, because I have to get in my car and I have to drive. Who's to say that I will not be the 1 or 2% that will be in a car accident and not make it?
So it's not about the patient alone?
It's not about the patient alone. We're taking that risk every day. Okay. When we get in the car, when we get on the plane, when we going about our business, crossing the street, people get hit by a car crossing the street. People get in a car accident all the time. When you drill it down all over the world, it's about 1 or 2%.
Great.
That's happening. But so, 99% people will do just fine.
All right. Comparatively, if you look at what humans can do, like you said, your vision level with this technology, it's far, far better than going, So tell us how this technology, are you able to use it remotely, or you just use it in the room?
That is correct. So just a little backstory.
All right.
This technology was originally meant to be used remotely. It was actually a military technology. Okay. But at the time that this technology was developed, we did not have the 5G network to be able to conduct anything remotely. So it lay dormant, and we decided we'll position the consult in the same room as the patient. Okay. But even in the same room as the patient, you're sitting in the corner, the patient is lying about 10, 20 feet away from you, and you're doing it remotely. Okay. So that begs the question, if you operate in 10 to 20 feet away from the patient, can you operate 100 feet away from the patient? Can you operate 200 feet, 300 feet?
A kilometer.
And then you can gradually increase the distance. Okay. And the answer is yes. It has been used to operate remotely.
Okay. What is the distance? Where maybe only on the continent of Africa, but you cannot cross the Atlantic, which means you cannot be in Africa and get operated upon in, say, the United States. Is that it?
It can be done. And it's being done, but it just hasn't been done yet.
Okay.
But I think that this is where it's going. This is the future. This is a whole idea behind this technology. And the idea behind this technology is essentially democratizing healthcare in remote parts of the world, whereby perhaps they may not have access to higher level of care.
Okay.
I'll give you an example. Suddenly, we have a young lady who is found to have a hole in the heart. They need to have that repaired. The surgery is expensive. Perhaps, we have experts here, or we do not have the experts here. And the patient has to be sent outside Ghana. As you know, the world is changing. Some places may say, we're not going to grant you the visa. Or even if they will, it has to go through the natural bureaucratic process that it takes. And what is not allotted to the patient is the luxury of time, waiting for the bureaucratic process to play out. What if a well-willing surgeon here in Ghana says, you know what, no problem. Let me call a friend, a colleague outside of Ghana, anywhere in the world, that can join me in helping do your surgery remotely. This brings about a collaboration in healthcare that never before been seen. Or perhaps a surgeon well capable of doing the operation right here in Ghana, and as they are doing the surgery, they run into a challenge. Now they would have the ability to dial in a friend, give me the access code right from my phone. I can log in and I can say, no, do this, do that, go here, go there, and guide and navigate them through the surgery successful. So all of a sudden, it's not just one surgeon in Ghana trying to treat you. That one surgeon in Ghana can invite other surgeons from all over the world with their wisdom, with their technology to help, right. Vice versa. Yeah. It works the other way around too.
Okay.
I could be in the United States and I could be faced with a disease that we don't see there very often. Okay. Particularly, let's say the disease of the mitral valve that is severely calcified, what have you. The developing world see that more often than we see in the United States, this type of disease. Okay. Is it possible that my colleagues in Ghana can say, oh no, we see this every day, this is how we do it. Okay. We can help you. So it can go both ways.
Right. Now, this technology, I'm interested in the kinds of surgeries it can conduct. Take us through.
So there's a variety of surgeries. So the garden variety of surgeries is, let's say, prostate disease. Okay. Patient with prostate cancer can have radical prostatectomy using the robot. The obvious difference between that and the open is that one of the biggest complications of prostate surgery is male impotence. Okay. You use the robot, that's almost zero.
Say that again. For the viewers who are men who have issues, tell us again.
When you have open prostate surgery, your risk of impotence is significantly high. However, if this done using the robot, your risk of impotence is almost near zero.
So that's one of the things
that's one of the benefits, yes, because the precision, you know, you don't have to destroy too many things to get to where you need to go. Okay. For our ladies that need fibroid surgeries and things of that nature, it can be used for that. Those that are going through hysterectomies, gallbladder, bowel surgery, just about any general surgery spectrum, it can be done. Then we can move into the world of thoracic surgery, which I specialize in, lung surgery. Okay. You know, you can use the robot to do that. And of course, the newest newcomer to be added to this repertoire is the cardiac surgery. And in cardiac surgery, we can do mitral valve, aortic valve, as well as coronary artery bypass. A combination of all the above.
So it means that this technology can do virtually any kind of surgery.
That is correct.
How about pathology?
Well, there's even emerging technology that are coming up that as you are removing a tumor, for example, right? One of the challenges that surgeons always face is that, did I get everything? Or am I leaving cancer behind? How can I tell? How do I know? There are features on this thing that would give you highlight and give you color differentiation that will tell you, yes, you got everything, or yes, there's some realm of tissue that you need to take more. Traditionally, we have to call our pathology friends and say, I need you to check the margin while the patient is still open. And sometimes like, well, I think everything is okay, except a week or two later, it's like, uh-oh, I think you were close to the margin. And then you're being told, maybe we need to take you back to cut some more or what have you. Can you imagine? But this happens.
Okay. But with this technology?
With this technology, it becomes less likely. Okay. Because again, the accuracy, the precision is significantly higher.
Is this affordable? Because it sounds so good, but here in Africa, we know healthcare is so expensive. In as much as somebody in Savelugu who cannot travel to the United States would want to take advantage of this particular technology to get treated, cost becomes a barrier.
No, I think you are absolutely right, and that is always a concern when it comes to emerging technology that will benefit us tremendously. But I would argue back that recent information that was released, that it was estimated that Nigeria alone spend over $6 billion a year with patients traveling from Nigeria to seek healthcare outside of Nigeria. I'm not sure what the number is for Ghana.
$6 billion.
$6 billion with a B. Traveling for various
Medical
conditions. So when you take that number, and that's from Nigeria, and you extrapolate that number, and you apply it not only to Nigeria, but to Ghana, to the whole west coast of Africa, not to mention
the entire
continent. Suddenly, this idea of affordability becomes a relative concept. And it begs the question, do we need to reorient our mindset and say, perhaps if we have this, that money will stay right here in the continent, in the economy, and will never leave, and eventually becomes cheaper. I will make the argument, when the iPhone first came out, only the rich can afford it. Suddenly, you go anywhere, the iPhone is being used just by virtually everybody. So affordability comes by the more utility you have for it, the more people that are using it, the price naturally will come down.
So what is the plan? Do we have any of such technology here in the country?
Currently, not to my knowledge.
Okay.
I don't believe we do. However, I do believe that we have individuals in this country, and not just this country, but on this continent, that have the ability and the intelligence to be able not only operate such technology, but also use it to save lives every day.
Right.
That I know for a fact, right? And so what I'm trying to do is, number one, bring awareness to this, and number two, partner with my colleagues here on the ground in Ghana.
Right.
And quite frankly, to even hopefully speak with the leaders like the Minister of Health or what have you, to seek their wisdom.
Okay.
Just like in our customs, whatever you try to do, it is better to seek the opinion and the wisdom of our elders. And to ask them how it would be best to bring this technology and how to integrate the technology into our current ecosystem to make it work. I believe that's probably the best way, because they know the lay of the land better than I would ever know. I think it's a good thing. I think it's a great technology, but I think I would need their guidance in terms of how best to go about it.
So you're concerned about how we can do this technology transfer where young doctors can have access to this equipment, and tell us about that.
Yeah, I think that, you know, the nature of this robotic technology is also one that I would love for our young doctors to get exposure to this. Just like if you know any young child who plays video game, and then you ask the parent of that child to compete with a young child on a video game, it's not even a comparison. And there's a joke about the word BBC, born before computers.
It's true, it's true.
You know, the young people are much more in tune, you know, with this technological advancements than even the, you know, the elder people, and they know this. And so I really believe that if we can get this technology in our young doctors that are coming out, they probably are used to digital platforms, computers, what have you. They grew up with it. This is what they do. They probably can type faster than they can write with a pen. And so understanding this, I think that having this in their hand, they can take it to the next level. And the nature of the platform allows us to also even do remote simulator training back and forth, and to get them up to speed on this technology.
Tell us the countries you've been providing help so far across the globe.
Yeah, so far, you know, we are developing courses and programs that allow other surgeons to acquire this knowledge. I have worked with surgeons from Saudi Arabia. Currently, I've just been invited to go to Qatar. I'm working with surgeons from Brazil, and obviously all over the United States. I've been invited to various institutions to speak and to help the teams learn how to use this technology and implement them in their daily practice.
Do you see the Ghana Armed Forces maybe being the first to consider something like this?
I think everything is possible. Everything is possible. And so, yeah, why not?
All right. So what would you want to say to policymakers in the country, from the health ministry, the government itself, in terms of starting this as a pilot program? I mean, we cannot bring all these machines, plenty of them, into the country, but where can we start from on a pilot?
I think the low-hanging fruit is, with the permission of the government, obviously, is that we get at least one robot down into the country as a research robot, whereby we basically use the simulators, have our young medical students, surgeons, from the students to the practicing surgeons, to get their hands on this machine, to play with the simulators. And the simulators is like a video game. No one will get hurt. No one is just spending your free afternoon testing how does this work, how does it move. And eventually, once you become comfortable with it, the rest is history. You can begin to see how this can be done. And so I think that if we can create a pathway to at least bring in just one and engaging with our
universities, for instance.
Universities or whomever. Not only that, in the universities, I'm thinking, obviously, the medical personnel that will be treating patients with this device, but also, why not our engineers, our engineering students, to also gain an insight to the technology, how does it work? Because after all, when you begin to scale it, something is bound to break. It would be nice that our engineers have an idea how to troubleshoot and navigate and fix it. So it's multifactorial, and it's an ecosystem that all of it has to play together.
Right, so we are still watching Dr. John de-Graft Johnson. He's a great man when it comes to medicine. You've listened to him. He's been doing exploits in the United States and across parts of the world. And we are discussing medical robots. Is that a word?
That is correct. Medical robots.
Medical robots. How much would this cost? A piece? You say we can start with one. How much in terms of cost?
Well, it depends on which company and what have you that you're trying to acquire, but it ranges anywhere between 500,000 to 2.5 million US dollars. Yes. So it depends on the complexity, which one you are looking for. But that's kind of where it is.
So even if we have it as a country, we're going to have challenge in terms of manning it. Reason we are talking about technology transfer. Is that a point?
Yeah, that is a point. But I think that, that is already happening with a lot of other digital platforms. How were we able to understand the smartphone? Whereas many of us, I remember growing up here, if you had a phone that was attached to the wall in your home,
you're privileged.
You were privileged. And now there are many people that never had that, but skipped that evolution and straight to a cell phone. And there are many people that never even had a bank account, but yet they're transferring money with mobile money and all these things that their parents or their grandparents wouldn't even have a clue what that's all about. So that's technology. And there's always a saying, necessity is the matter of invention. And I would actually tell you that the way Ghana uses digital money is actually much more fascinating and much more sophisticated than even how we use it in the States.
Really?
Yes, really. And let me explain to you why. Because, see, in the States, things moved in what I would call the evolutionary trajectory. In other words, everybody had a phone in the house plugged in. Then everybody transitioned from that to a flip phone. Then everybody transitioned together to a smartphone. And then every so often we upgrade and we keep upgrading. So it's a slow progression. When it comes to mobile money, for example, okay, most people would have had bank accounts in the United States. Then they would have had the Visa card. Then they would have had the MasterCard and a variety of plastics in the pocket. And then we also have, you know, the Zelle, the Venmo, different platforms. There's so many different things that are happening. So you have a variety of choices which way to pay for something.
So now, before we even get to the point where we can do that, where we have doctors from, say, London, US, South Africa, Brazil coming together to solve an issue, say, in Kigali, there should be a framework. Who needs to develop those framework?
I think that's going to come from all sorts of different, you know, sectors of society, right? Just like everything else that we do, right? We come up with the idea and we think it's a great idea. And suddenly somebody from the legal profession will say, but wait a minute. How do I know that you're qualified and you're from the United States and do you meet the same criteria that Ghana may have or vice versa? So here come the regulators with their laundry list of what would make it feasible. And there's an ethical moral component of it. Okay, do I pay more attention because you're the president of a country, so now I'm going to be all in, or you're a peasant? It's like, okay, yeah, I'm helping, but perhaps have a student practicing a remote surgery. How do we make it equitable? How do we make it, you know, legal, moral, ethical, and ensure that no matter who you are, we are providing you with the same standard of care. So that framework already exists in our current medical practice, whatever country that you are. If you go to any hospital, like even with my credentials, what have you, if I were to walk in Kolebu right now and say, hey, I'm here, I want to do surgery. It's like, wait a minute, hold that, time out. There will be somebody there, I'm pretty sure, that will want to make sure I have a medical license, want to make sure that whatever I claim to have is compatible with their system and it will translate. And there will be other surgeons there that will want to vet to make sure I really know what I'm doing and what I'm talking about. Yeah, so all these things are already in existence. It's just now translating that into the new platform and a new ecosystem that the world is coming to.
All right, so as we wrap up this conversation and we want this technology to come to Ghana, so I mean, the poor can also have access to world-class medical treatment. I would want you to look into the camera and maybe speak to policymakers about why there is the need for this technology to be started here in Ghana and for the government to at least consider setting up one center at least to start with.
So I think that, you know, obviously policy makers have to think not just the excitement of the process now, but also long-term in the future. At the end of the day, this technology is meant to help the general, public and the people. And in the medical world, we call that people the patient. It turns out that all of us are potential patients, and all of us someday might be on the receiving end of the scalpel. And when that day comes, we ask a simple question: what would we want? And from that vantage point, I want them to now start reverse engineering it. If you were be the one lying on that table and you asking the question, what would you want? What steps do you want to take now to make it possible that, God forbid, if that fateful day will come, we are ready? And we're not rushing to try to find some jet to fly you out of the country to get care elsewhere. That often has been a mindset, but what is not for sale is the luxury of time. You may have all the money in the world, but you may not have, but time is not for sale, and you may not have that time. And so if you don't have the time and you are have to be careful by here, can we put in the infrastructure in place to ensure that that care will be as good as anywhere else in the world?
Great talking to you, Dr. de-Graft Johnson. And he is the Ghanaian medical doctor who has been able to develop that technique to conduct surgeries remotely and to save lives across the world. This has been a conversation with him, and we are hoping that policymakers will take a cue from what he's been able to share with us here on this channel. My name is Calony. Thank you so much for watching. Bye-bye.